Okay, we're back from the break, and again, I thank you for tuning in on this rainy evening. And this is a live show. The call-in number should hopefully be at the bottom of your screen, 727, 727-8750. And again, please feel free to call in and ask me any questions you may have about any subject that's on your mind, not even one that we've even talked about on the show. Always like to maybe bring up a new topic and bring that into the forefront. So getting back to the previous discussion, I know it's a continuation of information I've stated before. I'd like to bring up things that I've talked about before, mainly because I think it's important to reiterate it. And sometimes I don't always say it in the manner that I can understand, or that I know that the consumer or the customer or the patient will understand. So sometimes they have to be stated in various forms and layman forms. I start talking sometimes and I go way over people's head, and I try not to do that. But sometimes it's just a natural thing as we get into this medical talking, and the next thing you know, we're talking about things that just are way over people's head, and they sit there and they look at you like, okay, but anyway. And then I can usually pick it up when people are lost in what I've said. But that being said, I'm trying to drive home this minimum inhibitory concentration, because one of the antibiotics out there that people use, or I see a lot of people use, is an antibiotic called Zithromax. And I wanted to try and make a slide for you, but I didn't have time to do that, that discovers or shows to you what I mean by putting the right antibiotic in the right location for what you're trying to treat. And that's very important for us, meaning that if you have an upper respiratory infection, there's a common group of pathogens that usually cause that upper respiratory infection. Obviously, if it's a cold or a flu virus, we're not going to treat that with antibiotics. But if it is a bacterial infection, most of those drain by natural gravity from your oral cavity, your nose and your mouth. And there's about 2 or 3 very prominent pathogens that usually that basically inhabit that area in your mouth. And depending on how often you get exposed to antibiotics will determine future infections, whether you'll need higher doses or a different antibiotic. And remember, different antibiotics kill bacteria. Either they kill bacteria, or which is bactericidal, or they're bacteriostatic, which means they hold them in check by what they do to that bacterial cell wall. So getting back to Zithromax, Zithromax is an intracellular antibiotic. It's called a Z-Pak. A lot of practitioners will give that to you because it's given for 1 pill a day. And there have been plenty of studies that show that if you take an antibiotic once a day, your compliance is nearly 80-something%. If you take it twice a day, it drops pretty dramatically to like 60% compliance. And from there on, it goes down pretty dramatically, meaning that if I give you a 4 times a day antibiotic, there's probably a 25% chance that you will be compliant with that antibiotic and remember to take it 4 times a day. So one of the things doctors like to do is give you something that they know you're going to be able to take, because it's a once-a-day antibiotic. And Zithromax fits that bill. It's called the Z-Pak, and it's like 2 pills and thing. And the reason is that they say it has such a long half-life. Well, what is a half-life? A half-life means that if I give you a particular product, let's suppose 100 milligrams of drug X, and it has a half-life of 5 hours, that means in 5 hours, half of that product will be left in your system of what I initially gave you. 5 hours later, half of that will be left, and 5 hours later, half of the half will be left. So if you do the math, you can understand that in order to maintain a good concentration of a 5-hour half-life drug, I would basically have to give you that drug somewhere between probably 7 to maybe 8 times a day. So as it drops off, you have a new dose that picks it back up, and you can maintain a reasonable, steady blood level of that particular antibiotic. If a drug, in the case of Zithromax, basically lasts 24 hours, then you would hope that the MIC would be greater than that's required to kill that bacteria for at least 12 hours. Well, in fact, it doesn't. It only lasts 2 hours above the MIC. So that's very dangerous, because if it's only 2 hours above the MIC and for the rest of the 22 hours it's in your system it's below the MIC, what do you think it would do? Well, first of all, it's not killing bacteria, and bacteria are being exposed to a subtherapeutic dose of that antibiotic, so therefore they're going to learn to live in the presence of that antibiotic and therefore develop resistance. Now, the danger part of that is okay, so you're resistant to Zithromax, so you just don't take it again. Well, what usually happens is they take it for 5 days and they call the doctor, oh, I didn't really get any better. So the doctor says, okay, here's another 5 days. So now it's even worse. Not only that, if you develop an allergic reaction to that particular antibiotic, it's in your system for 24 hours, longer really than that, because it has an incredibly long half-life. It's actually in the cells. It can maintain an allergic reaction for days and hours, I mean, probably weeks afterwards. So very difficult to treat an allergic reaction in that respect. It also would preclude you from taking a better antibiotic such as Biaxin, because it's in that macrolide group. So if an antibiotic is in a macrolide and you become resistant to it, you're not going to be able to take any of the other macrolides that are actually very, very good drugs, and one of those is called Biaxin. So if you happen to be in the presence of a practitioner who wants to give you a Z-Pak and you're watching this show and you can remember that, and if you don't remember the specifics, say, I think I'd like a different antibiotic. Unless, of course, you're treating an infection below the belt, such as an intracellular bacteria, such as chlamydia, or Legionella, or erysipelas, or one of those things that you might get in a and a couple of those are actually STDs. So chlamydia is a sexually transmitted disease in the below the belt. So it's a great antibiotic for that, but there are other antibiotics that are better. And one thing I like about quinolones, which are drugs we use to treat bronchial infections, is that it's very heavily concentrated in the bronchial mucosa. So when you take an oral antibiotic, it's very unlikely that you'll achieve IV levels of that particular antibiotic, because when a drug is taken by mouth, it has to be absorbed into your gastrointestinal tract based on food and how much blood flow you get in there, how well your intestinal tract is working. Then it has to be absorbed, and then it has to be bound to a protein, and then it has to go to where it needs to go. With an IV antibiotic, you bypass all of that, and you get super concentrations that are delivered throughout the bloodstream to the source of the infection. However, quinolones such as Cipro or Levaquin or Avelox are drugs that are very, very heavily concentrated in very specific areas of the body. One of them is the bone, one of them is the bronchial mucosa, or the congestion, and the other one is in the prostate and the urinary tract. So those drugs are very useful for treating, prostatitis, urinary tract infections. Uncomplicated urinary tract infections can be treated with ciprofloxacin for 250 milligrams for 3 days, because it's very heavily concentrated in the urine. And by limiting the dose of antibiotics in a period of time, you hopefully reduce the effectiveness, or not the effectiveness, but you reduce the risk of resistance and developing a secondary bacterial infection. And if you were to get a secondary bacterial infection from previous antibiotics, then it becomes super hard to treat. So those are the two antibiotics I like the most. Penicillin is very useful for, like I say, the common strep throat. As I reiterated in a previous show, the reason we treat strep throat with penicillin is to prevent the late autoimmune phase that comes from letting your immune system kill streptococcal bacteria. And as you know, there are some recurrences of certain viral illnesses that have come up, measles, and we've seen a resurgence of measles. And remember, vaccines are not an absolute panacea for prevention of those diseases. And there's no real way to test whether or not you're immune to measles, except maybe I don't even know if there's an antibody test. I think there is, but whether or not there's one that's available, that's what we would need to check and see with that. So, and of course, and I do believe that every once in a while we see measles because of a resurgence of people who enter this country that have not been treated with a vaccine. So that's how you get outbreaks in crowded public parks and things of that nature. And a lot of people don't get immunized today because they're afraid of the immunization issues that take place, such as the mercury and all the other scare tactics that they use out there. So immunizations are one of those things that are a personal thing. I do believe that in certain cases it's very useful, in certain cases it may not be. We're going to go to break here in just a few minutes, and when we come back, I'm going to go over some over-the-counter remedies that I think might be very useful to help prevent, if you do happen to get a flu or a cold, that might be very helpful. And some of those are easy to pick up. Some of them are kind of if you're a homeopath, you probably had some experience with these drugs, and if you're not, then we'll discuss those. So we'll be right back and bring those topics up. Thank you for tuning in.